It's a smooth day of cataract surgery until this happens. An anterior capsular tear in a toric IOL case. I want to make sure I finish this case in regulation and not in overtime, so I need all the help I can get. When we look at the literature, maybe there's something there that can help me. This 1991 paper perhaps has the answer. It was by no other than Dr. Ehud Assia working in David Appel's lab. Thank you, Ehud. What they found was anterior capsular tears in the extra cap era really didn't extend peripherally. In his cadaver study, they created 57 tears and none of them extended beyond the anterior capsule. When they looked up close, they found something that was pretty remarkable. The anterior zonules were bridging the tears, they were stretching, and they were preventing extension in most cases. Now, we know in the phaco era that we do see extensions, and that's because we use a pressurized environment. Two recent reviews of tears found between a 24% and a 50% extension rate. So what can I do to not meet that fate? The capsule, I learned from Dr. Assia, is like a trampoline, and we love trampolines here at Team North America. But like trampolines, too much force and the capsule can tear. So here are 5 anterior capsular tear countermeasures I can take, taking all I know from Dr. Assia's paper and the basketball court. We gently remove all the cortex, leaving the area of the anterior capsular tear for last. I like the one-piece silicone IA tip here because it is very gentle and delicate. It's very important, of course, to keep that trampoline in a planar position, so we use OVD with our second hand to make sure to keep the chamber stable. Now, this is an Aura case, and we're going to measure and mark like any other toric lens case, knowing that the toric axis is very close to the tear, but thankfully we have these one-piece acrylic IOLs which unfold like a gymnast. We can use a Kuglen hook to gently nudge and atraumatically place this into the proper positioning, again making sure not to press posteriorly or create any undue tension on this now gaping anterior capsular stretch. But I know those zonules are there, and I'm counting on Dr. Assia's paper to prove them right. It's very important to hydrate the incisions before the OVD removal. We don't want any shallowing or deepening, for that matter, at any point in this case. And here we can remove the viscoelastic safely and any other last fragments without having a shallowing of the chamber. And to complete the case, we hydrate one more time. But in this case, we don't rely just on that, and sutures will be malproductive perhaps in a toric refractive case. This is where ReSure ocular sealant comes into play, and we can ensure post-op recovery with absolutely no shallowing or movement of this lens. And that's the one place where a double dribble on the wound and the paracentesis is actually legal and lets us have a successful outcome.